independently from chair. It's required to instruct the patients to stand up from a sitting condition or from sitting on a chair. For this purpose, I ask the patients first to lean forward from the hip, alright? Just lean forward. Bring your body forward. Yeah. For standing up normally, we usually to stand up normally, we usually move the center of gravity forward, alright, and then we stand up like this one, alright. And without looking at the chair, we again back to the sitting position, alright. That's the normal activity in healthy neurological subjects. We move the body forward, lean forward, we move the center of gravity without any help from the objects around us. We stand up like this. We first ask the patient to try to stand up normally, alright? Try to stand normally without any assistance from the other objects around. And back to the sitting position, they usually do not turn the body, do not turn the head to look at the chair, because it will produce an asymmetry of the trunk if they try to turn the body and to look at the chair. For this purpose, first we ask the patient to try to normally stand, but most of the patients cannot do this normal standing up. And for this reason, we try to help the patients to show them a procedure to stand up safely. They have problems with their balance, they fear of falling. That's why they are reluctant to move the trunk forward, moving the center of gravity forward out of the base of sofa. To help the patients, we ask the patient to clasp the hands again, to move the hands forward, 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 like this one. Don't stand up, just. Alright, we ask him to move the body forward and back again. In this way, they will try to control their fear of falling. Alright, again, back again. Before standing up, the legs must be close together, parallel together, alright? We suggest to keep the affected leg a little bit behind the stand. Why? Because we want the patients to shift the body weight over the affected one when trying to stand it. Alright. But again, due to the spasticity and due to the fear of falling, they will not do that. When standing up, at the last moment, they move the stand leg behind the affected one and they shift all body weight over the stand leg. Alright. To control this, we first show you to perform with the legs being parallel, alright. Hands clasped, lean forward, looking at the point on the wall, and then we ask them to stand up with the legs being parallel. And without looking at the chair, sit down, again. But again, most of the patients are not able to do that. Again, due to the fear of falling. In this situation again, first the legs are parallel, alright? For example, assume most of the time the affected leg is spastic and they cannot keep the leg in flexed position. And most of the time they show the jerky knee extension. Show it please, like this one. And they cannot control the affected leg in this position. For this reason, the legs should be parallel first. We, in this way, will placing our foot in front of the leg, front of the foot of the affected foot. Again, the hands are clasped, lean forward, and stand up. But as I said, they have problem with standing. When they lean forward, they try several times, but as I say, due to the fear of falling, they cannot complete the procedure. In this situation, we control the affected foot with our foot alright by placing it in front of the foot, and we ask the patient to try to stand up. In this way, from the wrist joint as a key point, we help the patient to stand up. Alright? In this way, we control the extensor spasticity of the affected leg, and at the first stage, we help the patient to stand up. Again, we ask him without looking at the chair to sit back again. But as I said, if you don't control the affected foot, they will shift the body weight over the sound bone. Here, we assume the right side is the sound bone. How we do this? Again, the hands are clasped. Of course, the clasp hand moving it forward will help the patient to stand up. But at the last moment, they move the side foot a little bit behind the affected one. In this way, again, let me show you first. Let me show you by myself. While you're trying to ask the patient to stand up with the legs parallel, alright. At the last moment, as long as this side is the sound, at the last moment, in the last moment, they move the sound leg behind the affected one and they stand up. In this way, all the weight is shifted over the sound. But we want the patients to keep the body weight over the affected one. That's why it is preferable to keep the affected foot behind the sound. To control this, we control the affected foot by placing lightly our foot over the foot of the affected foot like this one. Alright? In this way we control it. Alright? We control the extensor spasticity of the affected leg. Alright? We don't allow the patient to move the affected foot forward, alright, to keep the sound bone behind. In this way, again, while the hands are clasped, we ask the patient to move the body, trunk forward, alright, and then to stand up. In this way, like. stable the affected foot. We stable the affected foot to control the sound one must be in parallel or being in a forward position. And the affected foot should be placed behind the sound one. In this way, when standing up, all the way is shifted towards the affected one. In this way, we use a weight bearing to stimulate the affected foot. Most of the patients cannot control the affected foot due to the spasticity. They show a jerky extension of the knee. That's why we need to control or place our foot lightly over the affected foot. Alright? After sometimes I showed you some techniques used to instruct the patient, to instruct the families of the patients to perform when they are out of clinic, when they act as a caregiver for their patients. We showed you how to use the bridging, to use, for example, the bedpan, or how to help them to come to the to over the edge of the bed, to move from the supine position to the sitting position. Alright? Now sometimes they are required to be moved from the over the edge of the bed to a chair, to sit over the chair. How we can use a technique to help the patient come to sit on a chair. Alright. What's the technique? To help the patients to come to sit on a chair from a bed, we first control the close together. The feet must be close together. As I said, due to the extensor spasticity, they cannot control the affected foot in place in this position. That's why in this way we can control the feet. Alright. With our knees close to the knees of the patient. In this way we control the legs of the patients. I ask the patient to use the hand, sound hand, to place it over the waist and hold on to me to control their body. But they are unable to move the affected upper extremity. In this way, I control the upper extremity, alright, with my elbow and the forearm. I use the arm with my shoulder to help the patient. I move it forward. I help the patient to come to the standing position, and with the rotation, I help the patient to come to sit on a chair. A quarter turn is required. You are required to position the chair with a quarter 45 degree against the bed. Again, I show it to you. First, you help the patient to come to a standing position, and then with the rotation, you help the patient to come to a sitting position on a chair. In this way, I control the legs with my knees close to the knees of I bring the patient to a sitting position on a chair. But sometimes they are unable to cooperate with us. In such situations, while I control the knees, I move the patient don't stand up. I move the patient forward and quickly with the rotation of the train, I move the patients from the bed to the chair. All right? Do you have any question? No. No problem. Of course, you will practice all of this and you will check it how to perform all these exercises. Yesterday I showed you how to help the patient to come to the ground to stand in position from a high bed. All right. I again repeated that technique, and then we continue this exercise with helping the patient to overcome the problems with the gait. I will show you how to train the stance phase of the gait, and then how to help the patient to use the swing phase of the gait. Remember that they have problems with activating the hamstring and those flexors. Therefore, they walk like this one. They hitch up the pelvis on the affected side because they cannot break the knee, break the lower extremity, to bend the knee, to walk normally like this one. Since the extensor spasticity is dominant on the affected side and they cannot bend the knee joint, they hitch up the pelvis, they push the pelvis up on the affected side with a rotation, walk like this one. This is named the circumflexion gait. Alright. Now I will show you how to control this type of gait to help the patient to bend the knee joint with a compensatory strategy. We will try to activate the muscles, hamstring and those flexors, to act voluntarily, selectively. But most of the time they have problems. We are not successful in activating these two muscle groups. So we need to use compensatory strategies to help the patient to walk normally, but using a compensatory strategy. Okay, to help the patient to come to a standing position from a high bed, all right, we stand close to the affected side. We hold the affected upper extremity, RIP, is RIP. I ask you to read the RIP, its definition and its component. And you see here the components of the RIP. I ask the patient first to support his body using the sound upper extremity, to bring the sound leg down, to place it on the ground, but not this one. Not this one, yeah. We assume it's a high bed. It's not adjustable. We assume this is a high bed. And now from this position, we want to help the patient to come to stand close to the bed. All right. While the sound leg is on the ground, we ask the patient to bring step by step the affected leg downward to place the affected foot on the ground. All right. As you see, the edge of the bed is helping the patient to keep the body balance. All right. And the edge of the bed will maintain the pelvis forward protraction position, not being retracted. In this position, I ask the patient to perform small ranges of flexion and extension of the affected knee joint like this one. Alright. After performing the flexion and extensions selectively, knee flexion extension voluntarily, I ask the patient to place the sound hand on the lap, not using the hand to support the body. Nor I ask them to come to the standing position or use the edge of the bed to support the pelvis to maintain it in protracted position. Okay, to stand up, back again, go back. Use the edge of the body to support the body. In this way, we will control the fear of falling of the patients. Now, as I showed you yesterday, I asked the patient, while keeping the affected, holding the affected upper extremity RIB to control the spasticity, I asked him to perform knee flexion and extension while the edge of the bed is a supporter for the body. Then I ask the patient to perform flexion and extension of the sound knee and then to perform the flexion and extension of the affected knee joint. Then alternate flexion and extension of the knee is requested from the patient. Perform while bending, for example, the sound one to extend the affected one, and alternate flexion and extension is used to prepare the patient for walking. Now I ask him not to lean back to the edge of the bed, and now again I ask all these exercises, flexion and extension together, flexion extension of the sounds knee, again affected knee, and then alternate flexion and extension of it. In this way, you will normalize the tonus. Any voluntary activation of the muscles will minimize, will reduce the spasticity on the affected side. Alright. The patients do not adopt to shift the body weight over the affected one because they believe that it's not strong enough to support my body weight. Therefore, most of the body weight is shifted towards the sound. We ask the patient to shift the body weight over the affected one, but they are reluctant to perform. How we can control these tendencies, observe this tendency, observe in patients with them. We use the shoulder or the trunk to shift the body weight towards the affected side. But again, they resist. When I want to move and shift the body weight towards the affected one, they resist with the movement. But I must shift the body weight over the affected leg, and I keep it in this position with the body weight shifted over the affected. In this way, you train the stance phase of the walking. In standing phase of the walking, body weight is shifted over the standing leg. Assume I'm moving the left leg forward and the right leg is experiencing the stance phase of the gait, bearing the weight of the body while I'm moving the left be able to bear the weight of the body. So while the upper extremity is held in RIP, I use the weight, I use the pelvis, I can use the shoulder or trunk to shift the body weight over the affected. Now I'm trying to move all the body weight like in a normal situation. When, for example, when my right leg is in swing phase, to move it forward, all the body weight is shifted towards the left side, all right? Now I want to train this stance phase for the affected leg. I first move the body weight towards the affected side. In this way, most of the body weight is shifted towards the affected leg. Now I ask him to raise the heel on the sound side a little bit, like this one. All right, step by step, I move the body weight to be shifted towards the affected leg. First, I ask him a little bit to raise the heel, like this one. Raise it and back on the ground. And then a little bit more. And then go to the toes, all right? In this way, most of the body weight now is shifted towards the affected one. After performing several times, while again from the pelvis or shoulder or trunk, I have moved the body weight towards the affected side. After performing this, I ask him to move the sound side forward. In this way, all the weight is shifted towards the affected one. In this way, the patients will be certain that the affected leg is strong enough to bear the weight when the sound leg is moving forward. Again, I show it to you. First, with the affected upper extremity in RIP, I move the body weight first towards the affected side. I ask the patient to raise the heel a little bit, to repeat it several times, and more raising of the heel joint to move towards the toes like this one, and then I ask him to move the sound leg forward. In this way, while the sound leg is in swing phase of the gait, the affected leg is experiencing the stance phase of the gait and is bearing all the weight of the body shifted towards the affected side. All right, and again, back. We repeat this technique several times to establish the stance phase for the affected lower extremity. Now, while performing this exercise, I ask the patient to repeat it again to move the sound leg forward. All right. Now I ask him to move the body towards the sound leg in this way. Body weight is now shifted over the sound, so in a stepping position. All right, the body weight now is shifted towards the sound side. Again, I ask him back. Just move.
Just
In a stepping, just shift the body weight back. Again, don't raise the foot. Don't raise the affected and sound foot when performing this technique. Again, move the body forward to shift the body weight over the sound one. But this should be in place. The affected foot should be not move, not raising the heel, alright? In this way, all muscles of the leg osseous is also stretched and elongated. In this way, body weight is moved towards the sun, leg as part of the normal walking. At the same time, the muscles, spastic muscles of osseous is elongated. We know that elongation of the muscle is one of the normalizing techniques offered in the NDT. Again, repeat it again. Yeah. In this way, he's learning how to shift the body in a normal manner when walking. Now, while the body is shifted in a stepping position over the sun side, I ask him to small ranges to bend and straighten the affected knee joint, like this one. Sometimes it's difficult for the patients to perform this flexion extension exercise. I can use I found the iliac crest here. Alright, I place my hand over the iliac crest and help the patient with pushing the pelvis downward and forward like this. In this way, he's or she will be able to easily bend and extend the knee joint on the affected side. Alright? While the pelvis is moved downward and forward with the help of trapeze. Alright, don't move. Straighten your knee. Alright. While the trapeze is moving the pelvis downward and forward, I ask the patient to close the affected knee joint to the sound knee joint. Alright? And repeat it again. As you see, we're trying to move the affected leg close to the sound one. The affected knee joint will be flexed. And this is a strategy we use to help the patients to use the knee flexion for swing phase of the gait on the affected side. Again, I push the pelvis downward and forward. I ask the patient to bring the affected knee joint close to the sound one. And then hold it here, move it close. Now move the affected leg forward and place it in front of the sound. In this way, you train the swing phase of the gait for patients with problems in bending the affected knee joint. Now, in stepping position, the affected leg moved forward. All right. We practice the stance phase for the affected leg. We showed you how to help the patient to bend the knee joint for the swing phase of the gait. Now, in step position, while the affected leg is in front of the sound leg, I again hold the affected leg in RIP. Why I hold the affected upper extremity in RIP? While I am working on the legs, on the walking of the patient. Why I hold the upper extremity in?
To avoid falling of the patients. Avoid falling of the patients
No.
and Stretch the muscles of the.
No. Why?
Related to associated reaction.
Yeah, of course. As you know, the fear of falling. All right. When you ask the patient to perform all these exercises, the fear of falling, they are learning new activities, and this will increase the spasticity of the upper leg through the associated reaction. And this associated reaction, increasing spasticity on the upper extremity, on the affected side, will influence the spasticity and activity of the lower extremity on the affected side. That's why the therapists hold the affected upper extremity in RIP to control the spasticity and associated reactions. With the background of normalized tonus, he will be able to perform these exercises. All right? That's right.
وانا تعب المرضى شو يسوي؟
All right. In this step position, now I ask him to move all the body forward over the affected lower extremity. All right? And back again. And repeat it. All right. In this way, step by step, gradually he's learning how to shift the body weight over the affected lower extremity, and this will help to control his or her fear of falling. And now he understands that the affected lower extremity is able to bear the weight of the body when walking. All right, and this will normalize the spasticity and tonus of the affected. May I ask you, what do you think about the best way to listen to me, please? Do you know, considering the basic theory of Bobak, what do you think about the best way of normalizing the tonus, spasticity of the affected lower extremity, and the best way to activate the muscles of the lower extremity on the affected side? Which procedure is the best one?
Placing them.
To elongate the gastrosoleus muscles and activate the muscles in a normal manner to be used in walking and standing. Which one? Which way?
Placing them.
No, not placing. The best way, one of the questions in the exam was this one. Which technique is the best one to elongate the, especially gastrosoleus muscles, normalize the tonus, and activate the muscles on the affected lower extremity, on the affected side for the affected lower extremity, to facilitate the walking in a normal manner? Which technique is the best one?
Bridging. We can use bridging.
Bridging? No. You have a patient with a stroke. He is suffering from the restricted ankle joint range of motion. All right. The muscles are contracted, suffering from contraction, is spastic. All right. And this patient is not able to use the lower extremity for walking, for standing. Which way you suggest to normalize the tonus, to lengthen the gastrosoleus muscle, and to activate the affected lower extremity muscles for walking and standing. All these beneficials, all these effects can be obtained with one technique. What technique is that? And you know which one? Yes. Which technique can be used? Which technique is the best one? There is Safiya. Zainab. Zainab.
With Zainab, we have 5 Zainabs.
5. I don't know. One of. Which one is Zainab?
Zainab.
Zainab.
Yeah. Recording me all the time.
We have 5 Zainab. He said. All right. What do you think? Yeah, Rohaya.
Yeah.
Oh, Rohaya. All right. What do you think, Rohaya? Muhammad. Abdul Karim. Oh, Abdul Karim. Yeah, answer. Muhammad is absent.
Muhammad Adil.
You don't have Muhammad?
Just 2.
Muhammad Adil. Which one?
Hassan.
Abul Hassan, what do you think? You don't. Yeah. No idea. The best technique. This may be one question in the examination. Best technique to elongate the gastroesophageal muscle on the affected side, to normalize the tonus, and to activate the lower extremity muscles for standing and walking. Which one is the best? Which technique you think is the best to obtain all these beneficials? Ankle dorsiflexion. To standing position, no. In supine position, perform, yeah. No other idea. What do you think? Just think.
Plantar and dorsiflexion.
You want me to answer, or you want to answer as one of your exam questions? Or want to analyze the theory as the technique to find yourself, which one is the best?
I think walking. Walking. Gait exercise.
Walking.
Best one.
That's right. Walking and walking is great. One of the best techniques to obtain all these beneficials is walking.
And jumping.
And the other component,
Jumping.
jumping.
انت تريد مريض ملف جلطة يقمص تساعدني.
ايه دي كان بقدر اسالك.
They even fear of falling when standing. How you want to ask them to jump? They can't jump. Walking is one of the techniques used. 50% of the answer is presented by others, and the half of the answer.
Walking and standing.
Walking and standing. Thank you very much. Excellent. Yeah, standing and walking. You can use just standing and walking to obtain all these beneficials to improve the affected legs. Instead of using all these techniques, just ask the patient to come to a standing position and force him to walk. Alright, is the height of standing and walking or the highest level of skills and function. That's why it's the best one. Alright, sometimes when you ask the patient to come to a standing position, you trigger the walking. She is wheelchair dependent, but with standing, just standing, they will be able to walk, and this act as a trigger for highest level of function for the lower extremity, standing and walking. All right. Now again, understanding, to train the stance phase of the gait for the lower extremity, not the same. With the legs parallel, I hold the upper extremity on the affected side in RIP. I again raise the heel first, go to the toes, and back again, repeat again. In this way, body weight is shifted over the affected one, and then move it forward and place it in front of that. Again back, and repeat several times. And now I ask him just use the tip of the foot to touch the ground and back again. Like this one. In this way again, when performed, all the body weight is shifted over the affected leg, and now he's expressing the stance phase of the gait. And in this way, you trigger the muscles to be activated, to be elongated, and to be ready to bear the weight of the leg. This is named tip-to-tip exercise for the stance phase. In practice examination, we may ask you to perform tip-to-tip exercise of the leg as a component of stance phase training for the affected leg. Alright? Now, with the sound leg in front of the affected leg, a little bit more in front of the affected lower extremity. Again, I ask the patient why I push the pelvis downward and forward. I ask him to lower the knee and close it to the sound. In this way, to bend the affected knee. Yeah.
Michael Jackson,
No, the sound leg must be maintained in extension. And now, after performing several times, again, move the affected lower extremity forward for swing phase of the gait. And in this way, the people with stroke will learn how to bend the knee joint when they are not activated, when the hamstring is not active to bend the knee joint. They will use this technique by moving the affected knee joint close to the soundbar. They will bend the knee joint to walk. Alright? Alright. Now we can make the exercise difficult for the patients. To move the body weight again towards the affected leg. I ask the patient to stand with crossed leg. Sound leg in front of the affected one in this way. While the hands are clasped, I ask the patient to stand with crossed leg. Sound leg in front like this one. Alright? Again, back. In this while trying to perform this technique, this exercise, all the body weights again will be moved, will be shifted towards the affected body. And it's really difficult. It's a challenge for the patients. You challenge the patient to perform this exercise. And now I ask the patient, while after performing the cross-leg standing, to make a figure like English A like this one. Again, it's challenging the balance of the patients with exercise. And this prepare the affected leg for stance phase of the day. Alright. Now I ask him to raise the sound leg actively, alright, to shift the body weight over the affected one, like this one. Of course, it's really difficult. They will do like this one. Alright. Do you perform it normally? It's a normal reaction when you ask them to raise the sound leg or one of the legs. Alright. In this way, I bear the weight all the time. For example, when the eyes are open. But in patients with hemiplegia, when you ask this question, this exercise is really challenging for the patient. It's really difficult. Just for 1 second, they feel like this one, or like this one. But you need to ask the patient to perform this. And step by step, the time to bear the weight on the affected lower extremity with raising the sound leg, they will be able to bear the weight over the affected lower extremity. Therefore, one of the exercises is asking the patient to raise the sound leg and back again to place the sound foot on the ground. Yeah. And you can make the exercise more challenging again. Why raising the sound leg? Ask him to keep the sound leg raised while performing knee flexion and extension on the affected side. While bearing the weight on the affected side, he is performing selective knee flexion and extension, voluntary knee flexion, and they are advanced exercises for the patients. Alright? Okay. Now, consider a line like this one, alright? Ask the patient to touch the hands, stand behind the line here, move first towards the, not like this one, this one.
Okay.
Go ahead. And now move towards the affected side. Not moving forward or backward, just behind the line, alright? Again. Which one is difficult for the patient? Walking, side walking towards the sound side, or side walking towards the affected?
The affected side, because he wanted to shift the wet body weight to the affected, and that's
Walking, side walking towards the affected side is really difficult for the patients. And they cannot control the body to follow the line. Keep the body behind them. They move forward, backward, especially when you ask the patient to side walk towards the affected side. It's really a challenging. Now, suggest an exercise with side walking to challenging more the patients with hemiplegia. What exercise you suggest to challenge exercise, all right, how you can make it difficult and more challenging for the patients?
But I give him a time.
Show it to me.
I put, for example, ask the patient to move his sound leg, and after that, shift the body over it and calculate to 5 seconds or 10 seconds, and after that, I think 1, 2, 3, 4, 5, 1, 2, and again hit the body.
ممكن يعيش الخطوة ويسوي سكوات
Name.
ومو قاعد سكوات بس. One step and after that do one squat.
Ask him to perform.
بعد تعوز على ما تعوز
He said, do the movement, the sound, move the sound leg, and after that do squat, and after that squat.
Although will challenge the patient, and is also said this exercise, all right, but more challenging and dynamically. Move alongside the line.
Walking side walking on the tips and
Lateral border of the
One more challenging technique can be
fingers or the
walking, side walking, all right, with crossing the leg. And this is really difficult for the patients, like this one. All right, going back with the sound. Cross leg is really difficult for the patients. And now, dynamically, I ask them to walk with legs crossed. Go ahead. Hands clasped together.
Michael Jackson form.
And now I ask the patient to walk forward with legs crossed again. In this way, again, you challenge the walking coordination. You also challenge the balance of the patients. One important walking is walking forward to 3 steps and then walking backward. In this way, walking backward will improve walking forward. With
Crossing
hands
legs.
clasped, no. Normally walk 1, 2, 3, and then backward. 1, 2 steps backward. Again, 1, 2, 3, forward walking, and then walk backward. Alright. Hands clasped. Yeah. Forward. Okay. Why it's an important exercise for the patients, and why this improves walking forward in patients who are sick. Why walking backward will improve their forward walking. أولا سنة. Why?
Because the name of receptors which is responsible for the base leaf to it. Because it will stretch the back muscles.
Back muscles.
Yeah, of the leg, back of the leg, hamstring and gastrocnemius. Will stretch during backward.
Stretch. Control. Why backward walking can improve walking forward. Why? walking will improve forward walking. Alright, like this one, and again forward walking. Why backward walking improves the forward walking in patients with stroke? That's an important one. Why? I don't know. Excellent. Just 1 minute.
ما أنا دور أحد أنا.
Let's ask. What's your name? What do you think? Why backward walking? Analyze my walking. Analyze my watch. Alright. Watch how I walk forward and analyze walking backward. Kinematically, analyze the lower extremities when walking backward.
Synergically.
Analyze my joints on the affected side, alright? Analyze my leg movement. Analyze the leg movement. Alisa, you found it? Analyze it. You are required to analyze the movements. Alright. Again, analyze my leg movement when walking backward. Did you find it? Because backward walking activates the hamstring to bend the knee. Analyze the leg movement. Alright? In this way you activate the hamstring. It's required for walking normally. That's why we use backward walking, alright, to activate the hamstring actively. Now in standing position, I'll use the facing maneuver to assess whether the postural reflex mechanism is working or not. This problem with postural reflex mechanism when dropping and supporting the lower upper extremity with the upper extremity in abduction at the shoulder. Now it's normal. When you drop it, you can control it. In patients with hemiplegia, they cannot control it. This indicates that the patients have problem with the muscles around the shoulder and postural reflex mechanism. Now I can activate the muscles around the shoulder, like this one. I try to suddenly drop it. In this way, the muscles around the shoulder, deltoid supraspinatus, will be activated. And step by step, you will be able to maintain the upper extremity abduction for seconds first, activating the muscles reflexively around the shoulder, like this one. First, I use this technique to activate the muscles. Alright. What technique now I can use to activate the muscles around the shoulder, especially the abduction? shoulder abductor.
Circumduction.
Abduction or extension plate?
First I use the reflex stimulation to activate the muscles. Alright, reflexively I activate the muscles. Alright, in this way. And with stretch reflex stimulation, the muscles will be activated for moments first, for the second, and step by step, the patient will be able to contract the muscle. When activated reflexively, we can ask the patient to voluntarily try at the same time with the reflexive activation of the muscle to hold the muscle, to place the muscles in this position with shoulder abduction and elbow extension. Now, what technique I can use to activate the muscles actively to raise the upper extremity into abduction? Activators, they are not able, you cannot activate the muscles. They are not able to actively raise the upper extremity into abduction. First, I showed you we can use the stretch reflex to trigger the stretch reflex to activate the muscles. Now, what technique, according to the MDT approach, I can use?
Placing.
Placing maneuver. How? We hold the upper extremity in this position. Alright? The starting position of placing maneuver is the final end range of the desired movement. Now I ask him to be relaxed, to get the muscle relaxed, while I passively lower the upper extremity towards the gravity, towards the abduction. If he is able to control his spasticity, not pushing against my hand, I ask the patient to reverse the movement, to move it towards the abduction activity. Now we assume the second scenario. He is not able to control the spasticity. While moving, he will push against my hand. How will we push him? It will be like that. While pushing against my hand, that's why I place my hands here. In this way, I will understand he is pushing against my hand. They will pull the upper extremity towards the typical postural flexion. Alright. Now, while moving downward into abduction, they will push against my hand. Therefore, I ask him to be relaxed. Back to the previous stage, I ask him to be relaxed, to let me move it passively into abduction like that. If he's able, we assume now he's able. If he's able to control his spasticity, he will be able to abduct the upper extremity. We just follow the movement with the patient. We keep the placement of the hands. Now he is able to place the upper extremity in the abduction position. But it is not like that. Alright? It's the ideal game when when rehabilitating patients with dementia. They will have this posture. They will show this one. But it's desired. We do not expect to have a normal position of the limb like that. The spastic muscle, even will pull the that's the question Ali's yesterday asked me, how they show these improvements. One of the, in fact, the figures observed even when obtaining an ability, for example, holding the shoulder joint abduction, will be in some typical posture, even for upper extremity and lower extremity, while he may be able to place the upper extremity in abduction, but typical posture will be observed like that. This is not completely with shoulder abduction or shoulder lateral rotation. It will be with some internal rotation and the elbow in some flexion and forearm in pronation. Alright? Again, standing position. I ask the patient to clasp the hand, to raise the upper extremity, up, to face the hand behind the head, again back to the, no, back to the elevated posture, to bring it and place it on the thorax, and now extend it, bend it, elevate it behind the head, again extend it, thorax, repeat it again several times. Now I ask the patient to extend the wrist joint and fingers with turning the hand like this. Now again, no, this one, again, behind, extend the thorax, then like repeat several times. But it's not easy for the patients to hold this posture and perform this exercise. Alright, now I ask the patient to place the hands on the bed. Alright, again, you are required to extend the fingers and abduct the thumb and fingers. You are required even, for example, this side is affected, to hold the fingers in abduction and extension. It is easy for the patients to have the fingers in abduction and extension. Alright. They may even have fisted. Sometimes they are not able to extend the fingers. Alright. If they are not able to extend the finger, we may ask the patient to hold the posture with the fingers fisted. Now I ask him to walk backward with the hand placed on the bed. I ask him to walk backward and forward. Again, in this way. Yeah. Well, in severe cases with hand spasticity, before performing this technique, I suggest use the dry needle to reduce the spasticity immediately. Alright, even just inserting the needle into the muscles will reduce the spasticity immediately. And then you can open the fingers into extension and then again repeat it forward and back. Why we are performing this exercise? What are the beneficial Analyze the movement, please. What are the beneficials of this exercise?
Doing walking exercise without fear of falling.
Without fear of falling. They always have fear of falling. Even walking independently. Always they have fear of falling. It's irrelevant.
Dr. Shifting of weight.
Shifting, not shifting.
Stretch of muscle of hamstring rest.
Again, please.
Stretch to the hamstring.
Stretch the hamstring.
اكو رد فعل دفاعي يتعامل مع الحيوان. رد فعل دفاعي ما راح يحكي عنه. كان اسمع عن المحاضرة شنو كان اسمه؟
وهذا الآر
Yeah, one, again. Weight bearing over the upper extremities. One, the beneficial effects of weight bearing on the affected upper extremities. Second, walk backward, then downward. Backward, weight bearing over the affected upper extremity. I said before, the second beneficial effects of this
hamster. الهامستر.
what? Activating what? Hamstring. It's backward walking. Again. It's backward walking. Hamstring muscle